The ligaments of the ankle, the structures that provide stability, guide motion, and determine how the ankle responds to injury. Without understanding the ligaments, it is impossible to fully grasp the mechanics of ankle sprains, syndesmotic injuries, or even the classifications of ankle fractures we have already studied. The syndesmosis, guardian of the ankle mortise. At the highest level, we must begin with the distal tibiofibular syndesmosis. This is not a single ligament, but rather a complex of 4 major structures that stabilize the distal tibia and fibula around the talus, forming the ankle mortise. The anterior inferior tibiofibular ligament, AITFL, runs from the anterior tibial tubercle to the distal fibula. It is strong and oblique, resisting external rotation forces. It is the first ligament to fail in high ankle sprains. An avulsion of its bony attachment produces the classic Tarot fracture in adolescence. The posterior inferior tibiofibular ligament connects the posterior tibia to the fibula. It is weaker than the AITFL, but critical in maintaining posterior stability. Rupture here may accompany posterior malleolar fractures. The inferior transverse ligament also lies deep to the PITFL and provides additional posterior support, essentially functioning as a labrum for the talus. The interosseous ligament, IOL, is the distal thickening of the interosseous membrane. It binds tibia and fibula tightly together, resisting diastasis under axial loading. The syndesmosis is the primary support of the ankle mortise. If torn, the fibula will displace laterally, and the talus will shift, producing instability. This is why syndesmotic injuries, high ankle sprains, are so disabling and require long recovery. In fractures, especially Weber's C injuries or pronation external rotation patterns, syndesmotic disruption must always be suspected. The ankle joint capsule. The ankle is a hinge joint, or more precisely, a ganglimus, that primarily allows dorsiflexion and plantar flexion. The capsule extends from the tibia and fibula to the talus, but its stability is not uniform. Instead, stability is provided by 3 key groups of ligaments: the lateral ligaments, the medial deltoid complex, and the syndesmotic ligaments we already described. The lateral ligaments, guardians against inversion. On the lateral side, 3 ligaments resist excessive inversion and anterior translation of the talus. The anterior talofibular ligament runs from the lateral malleolus to the neck of the talus. It is the weakest and most commonly injured ligament in the ankle, especially during inversion sprains. The AITFL is the first line of defense against anterior translation of the talus, and it is the #1 injured ligament in sports. The calcaneofibular ligament runs from the tip of the lateral malleolus down to the calcaneus, just posterior to the peroneal tendons. It is stronger than the AITFL and resists inversion, particularly when the ankle is in dorsiflexion. It is the 2nd most commonly injured ligament in ankle sprains. The posterior talofibular ligament runs from the fibula to the posterior talus. It is the strongest of the 3 lateral ligaments and is rarely injured in isolation. Injury of the PTFL usually occurs in the setting of severe ankle dislocations. Together, these 3 ligaments stabilize the ankle laterally. They explain why inversion injuries are so common. The lateral ligaments are thinner and weaker than the medial complex, and the lateral malleolus sits lower, making the talus more prone to rolling outward. The medial ligaments, the deltoid complex. On the medial side, stability is provided by the deltoid ligament, a broad, fan-shaped complex divided into superficial and deep components. The superficial deltoid has 3 main parts: the tibionavicular ligament, extending to the navicular, the tibiocalcaneal ligament, extending to the sustentaculum tali, and the anterior tibiotalar ligament, extending to the talus. The deep deltoid is composed mainly of the posterior tibiotalar ligament, which attaches from the medial malleolus to the posterior talus. The deltoid ligament resists eversion of the ankle. It is thick, strong, and rarely injured in isolation. When disrupted, it is usually in the setting of severe pronation injuries or in combination with fractures such as Weber C fibular fractures. In radiographs, medial clear space widening indicates deltoid rupture, and this is always a sign of instability. Functional importance. The balance between the lateral and medial ligaments explain the patterns of ankle injuries. Because the lateral ligaments are weaker, inversion sprains are by far the most common. Eversion injuries, resisted by the deltoid, usually cause fractures rather than isolated ligament tears. From a biomechanical perspective, the AITFL stabilizes the ankle in plantar flexion. The CFL stabilizes it in dorsiflexion. The deltoid resists eversion throughout the arc of motion, and the syndesmosis secures the mortise and prevents the fibula from splaying outward. Thus, every ligament has a role at a different position of the ankle, and injury patterns make sense when we consider these roles. Clinical correlations. Understanding these ligaments is essential in practice. A simple inversion sprain may involve only the AITFL, producing lateral swelling and tenderness. A more severe inversion injury may rupture both the AITFL and the CFL, producing instability. Complete disruption of the lateral ligaments with or without syndesmotic injury results in gross instability and often requires surgical repair. High ankle sprains involving the syndesmosis are particularly problematic. They occur with external rotation or dorsiflexion injuries and result in prolonged disability. If not recognized and stabilized, they can lead to chronic instability and arthritis. Medial clear space widening on radiographs is a red flag for deltoid rupture. In these cases, even if the fibular fracture is aligned, the ankle mortise is unstable and fixation is necessary. Summary. To summarize, the ligaments of the ankle form an intricate system that stabilizes the joint and determine patterns of injury. The syndesmosis maintains the mortise. The lateral ligaments resist inversion, but because they're weaker, they are the most commonly injured. The medial deltoid ligament is strong and resists eversion, but when ruptured, it signals instability and often accompanies fractures. By carefully understanding the anatomy and function of these ligaments, we can predict injury mechanisms, interpret radiographs accurately, and plan appropriate treatment. In ankle trauma, the ligaments tell the story behind the bone fractures, and without their understanding, our treatment will always be incomplete. The lateral ligament complex. We begin with the three classic components of the lateral collateral ligament of the ankle. The anterior talofibular ligament, or ATFL, extending from the anterior aspect of the lateral malleolus to the neck of the talus. It is the weakest of the three and the first to rupture in inversion sprains. It resists anterior translation of the talus when the foot is in plantar flexion. The calcaneofibular ligament, or CFL, running from the tip of the lateral malleolus down to the lateral wall of the calcaneus. It is extra-articular and cord-like, resisting inversion when the ankle is dorsiflexed. The posterior talofibular ligament, or PTFL, extending from the malleolar fossa of the fibula to the posterior process of the talus. It is the strongest and is rarely injured in isolation, but can fail during frank ankle dislocations. These three ligaments formed the cornerstone of lateral ankle stability, and their injuries define the spectrum of inversion sprains, from mild ATFL tears to combined ATFL and CFL ruptures, and finally, to catastrophic dislocations involving the PTFL. Other key ligaments seen laterally. Beyond the classic triad, several other ligaments are visible in the lateral view. The interosseous talocalcaneal ligament, which stabilizes the subtalar joint. The cervical ligament, also a critical stabilizer of the subtalar joint, especially against inversion. The bifurcate ligament, a Y-shaped structure with two arms, the calcaneonavicular ligament and the calcaneocuboid ligament. This bifurcation is vital for stabilizing the Chopart joint. The long plantar ligament running from the calcaneus to the bases of the metatarsals, contributing to longitudinal arch stability. The dorsal tarsal ligaments, including the dorsal talonavicular, calcaneonavicular, cuboid, cuneonavicular, and tarsometatarsal ligaments, which collectively bind the midfoot and resist excessive motion across the tarsal joints. Retinacula and tendons. In this same view, we also see the fibular retinacula, the superior fibular retinaculum holding the peroneus longus and brevis tendons behind the lateral malleolus, the inferior fibular retinaculum securing these tendons as they curve around the calcaneus. Disruption of these retinacula can cause peroneal tendon subluxation, an important but often overlooked cause of chronic lateral ankle pain. MRI correlation, axial view. Now let's correlate with imaging. In the axial MRI view, you can clearly appreciate the anterior talofibular ligament, or ATFL, running obliquely from the fibula to the talus. The peroneal tendons coursing behind the lateral malleolus, stabilized by the retinaculum. The Achilles tendon posteriorly inserting into the calcaneus. The medial and lateral malleoli framing the talus. This view is critical for detecting ATFL tears, which appeared as discontinuity or high signal intensity on T2 weighted images. It also helps to evaluate peroneal tendon pathology, such as tenosynovitis, tears, or dislocation. MRI correlation, coronal view. In the coronal MRI view, we see the fibula laterally and the tibia medially. The medial malleolus and lateral malleolus framing the mortise. The talus sitting between them, forming the ankle joint. The calcaneofibular ligament descending from the fibula to the calcaneus, often visualized as a dark cord-like band. This view is especially helpful in assessing CFL injuries, as well as in evaluating joint effusion, osteochondral lesions of the talus, and alignment of the ankle mortise. Clinical relevance. From a clinical standpoint, the combination of anatomy and MRI correlation allows us to understand the injury spectrum. Grade 1 sprain, stretching of the ATFL, often normal on MRI or with minimal edema. Grade 2 sprain, partial tear of the ATFL, sometimes with CFL involvement, seen as increased signal and thickening on MRI. Grade 3 sprain, complete rupture of the ATFL and CFL with instability of the ankle. In severe cases, the PTFL may also be disrupted. MRI is invaluable not only for diagnosing ligament tears, but also for evaluating associated injuries such as bone contusions, osteochondral lesions, or peroneal tendon pathology. Summary. To summarize, the lateral ligament complex, ATFL, CFL, and PTFL, is the most clinically relevant group, with the ATFL being the most frequently injured. The subtalar ligaments, interosseous and cervical, provide stability to the hindfoot, while the bifurcate and dorsal tarsal ligaments secure the midfoot. The fibular retinacula prevent peroneal tendon subluxation. MRI, both in axial and coronal views, provides direct visualization of these ligaments and tendons, confirming the diagnosis and guiding treatment. This integrated understanding of gross anatomy, functional anatomy, and imaging correlation is essential for every orthopedic surgeon and radiologist. It ensures that when you see an ankle sprain, you don't just think of a simple ligament tear, but rather of the complex three-dimensional stabilizers that must all be considered to restore proper function. Let's now turn to the medial view of the right foot, one of the most complex and clinically significant perspectives in foot and ankle anatomy. This view allows us to appreciate the intricate relationship between bones, ligaments, tendons, and the supportive structures that maintain the stability of the medial longitudinal arch, which is essential for locomotion and weight-bearing. The images you see here provide both a classical anatomical dissection and MRI correlation, bridging pure anatomy with real-world clinical imaging. Bones in the medial view. We start with the bony architecture. The tibia descends medially to form the medial malleolus, a palpable bony landmark that serves as a key attachment for several ligaments. Inferior to the tibia lies the talus, which articulates superiorly with the tibia and fibula to form the ankle joint, and inferiorly with the calcaneus at the subtalar joint. Anteriorly, the talus articulates with the navicular bone, which itself is a keystone in the medial arch. The sustentaculum tali of the calcaneus projects medially, acting as a shelf that supports the talus and provides a pulley for tendons. More distally, we can see the medial cuneiform bone and the first metatarsal, structures that play a pivotal role in the first ray and in propulsion during gait. Ligamentous structures, the medial deltoid ligament. The most important ligamentous structure in this view is the deltoid ligament of the ankle, which is not a single ligament, but a complex of 4 parts. These include the posterior tibiotalar part, the tibiocalcaneal part, the tibionavicular part, and the anterior tibiotalar part. Together, they form a fan-shaped structure originating from the medial malleolus and spreading to insert on the talus, calcaneus, and navicular. Functionally, the deltoid ligament resists excessive eversion of the foot and stabilizes the ankle joint, particularly against valgus forces. Just inferior to this, we observe the medial talocalcaneal ligament connecting the talus to the calcaneus and the posterior talocalcaneal ligament, which provides additional reinforcement to the subtalar region. The spring ligament complex. Another structure of tremendous clinical importance is the plantar calcaneal navicular ligament, more commonly known as the spring ligament. This ligament runs from the sustentaculum tali of the calcaneus to the plantar surface of the navicular. Its role is to support the head of the talus and to maintain the medial longitudinal arch of the foot. When this ligament becomes attenuated or ruptured, often in cases of posterior tibial tendon dysfunction, patients may develop acquired flat foot deformity, a condition that severely impairs mobility and quality of life. Adjacent to the spring ligament, we also encounter the short plantar ligament and the long plantar ligament, both of which contribute to the overall integrity of the plantar arch system. Tendinous structures in the medial view. Now let's focus on the tendons. The tibialis posterior tendon courses inferior to the medial malleolus, inserting onto the navicular tuberosity and medial cuneiform, but also sending slips to the other tarsal bones. This tendon is sometimes referred to as the main dynamic stabilizer of the medial arch. Dysfunction of the tibialis posterior tendon is a key pathology leading to progressive flat foot deformity. The tibialis anterior tendon, although primarily visualized from a more anterior perspective, also inserts on the medial cuneiform and base of the first metatarsal, playing an important role in dorsiflexion and inversion. Finally, the Achilles tendon can be seen cut in this dissection, inserting on the calcaneal tuberosity posteriorly. While not directly part of the medial support, its relationship to the calcaneus is critical for plantar flexion strength. MRI correlation.
The MRI images provide us with a clinical window into these structures. In the deltoid ligament MRI view, we can appreciate the medial malleolus, the deltoid ligament complex, the talus, calcaneus, and lateral malleolus. This imaging is essential in diagnosing ligamentous injuries, particularly in the setting of ankle sprains, where the integrity of the deltoid ligament determines treatment planning. In the sagittal MRI, we can clearly identify the tibial plafond superiorly, the head and neck of the talus, the navicular, and the flexor hallucis longus tendon coursing posteriorly. This tendon passes beneath the sustentaculum tali, a detail that is often tested in anatomy examinations. Clinically, MRI is indispensable in evaluating talar neck fractures, osteochondral lesions, and tendon pathologies. Clinical relevance. Understanding the medial view of the foot is crucial for orthopedic practice. Injuries to the deltoid ligament complex are less common than lateral ankle sprains, but when they occur, they are often associated with severe trauma, including fractures and dislocations. The spring ligament complex and tibialis posterior tendon are key targets in the evaluation of adult-acquired flat foot deformity. Furthermore, fractures of the sustentaculum tali, talar head, or navicular bone can significantly destabilize the medial arch and demand precise surgical intervention. MRI provides unparalleled detail in soft tissue evaluation, making it essential for identifying partial tears, tendon degeneration, and subtle osteochondral lesions that might not be visible on plain X-rays. Summary. In summary, the medial view of the foot reveals the harmonious interplay between bones like the talus, calcaneus, navicular, and medial cuneiform, ligaments like the deltoid and spring ligament complexes, and tendons like the tibialis posterior. This arrangement ensures both stability and flexibility, allowing the foot to withstand the immense forces of locomotion. Disruption of any of these components, whether by trauma, degenerative disease, or congenital anomalies, can lead to profound functional impairment.
Let us now focus on one of the most intricate yet clinically crucial parts of foot anatomy: the ligaments and capsules of the metatarsophalangeal and interphalangeal joints and the system of intertarsal joints that together create the unique mobility and stability of the human foot. As you can see in the lateral and plantar views illustrated in this figure, the phalanges are stabilized by joint capsules and collateral ligaments, just like in the hand. But the foot, unlike the hand, has to resist body weight with every single step. That means its capsules and ligaments are reinforced differently, designed to prioritize stability under load while still allowing the fine movements necessary for balance and propulsion. Metatarsophalangeal and interphalangeal joints. Each metatarsophalangeal joint, or MTP joint, is surrounded by a capsule that is strengthened medially and laterally by collateral ligaments. These ligaments prevent excessive lateral deviation of the toes. On the plantar aspect, we find the plantar ligament, or plantar plate. This structure is thicker than the dorsal capsule, reflecting the need to resist ground reaction forces. The plantar plate also provides a surface over which the flexor tendons glide, essentially functioning as a pulley system that increases the efficiency of toe flexion during push-off. Clinically, degeneration of this plantar plate is a key factor in metatarsalgia and deformities such as hammer toes or crossover toe deformity. In fact, rupture of the plantar plate at the second MTP joint is a common cause of instability and pain in athletes and in patients with rheumatoid arthritis. The interphalangeal joints, the hinge joints between the phalanges, are simpler, but again reinforced by collateral ligaments and plantar plates. These prevent abnormal medial or lateral deviation, while allowing flexion and extension.
The collateral ligaments are especially important in preventing varus and valgus deformities of the toes, which are often seen in traumatic dislocations or chronic deformities like rheumatoid forefoot. Intertarsal joints, subtarsal joint. Moving proximally, let's consider the intertarsal joints, starting with the subtarsal joint. This joint, also called the talocalcaneal joint, is a marvel of design. It articulates through three distinct facets between the talus and calcaneus. The subtarsal joint allows inversion and eversion movements, which are essential for adapting to uneven surfaces during walking. The stability of this joint depends heavily on its ligamentous support. The calcaneofibular ligament, already familiar from the lateral ankle, also contributes. But intrinsic stabilizers dominate. The interosseous talocalcaneal ligament in the tarsal sinus, the cervical ligament, and the medial and lateral talocalcaneal ligaments. Together, they act like check reins, preventing abnormal tilting of the talus on the calcaneus. Clinically, injury to these ligaments, especially the interosseous talocalcaneal ligament, is a common cause of chronic hindfoot instability. And during subtarsal dislocations, reduction can be blocked by interposition of the extensor digitorum brevis muscle or even the posterior tibial tendon. Transverse tarsal joint, Chopard's joint. Just anterior to the subtarsal joint lies the transverse tarsal joint, also known as Chopard's joint. This includes the talonavicular and calcaneocuboid joints. The talonavicular joint allows significant rotation and functions almost like a ball and socket, with the convex head of the talus fitting into the concavity of the navicular and spring ligament. This ligament is crucial. It not only supports the talar head, but also maintains the medial longitudinal arch. Loss of integrity of the spring ligament is one of the fundamental causes of acquired flat foot deformity, especially in posterior tibial tendon dysfunction. Radiographically, collapse of the talonavicular joint line is one of the earliest signs of this condition. Calcaneocuboid joint. The calcaneocuboid joint contrasts with the talonavicular joint. Its surfaces are relatively flat, reinforced by a series of strong plantar ligaments, the long plantar ligament, the short plantar ligament, also called the plantar calcaneocuboid ligament, and the dorsal calcaneocuboid ligament. Together, they prevent abnormal motion and help stabilize the lateral longitudinal arch. When the calcaneocuboid joint is injured, such as in midfoot fractures or dislocations, patients often develop chronic lateral foot pain due to instability. Functionally, this joint, along with the talonavicular joint, determines whether the foot is flexible or rigid during gait. Other intertarsal joints. Finally, we must mention the other intertarsal joints, such as the cuneonavicular, intercuneiform, and cuboidonavicular joints. Each of these has its own small dorsal, plantar, and interosseous ligaments. They may seem minor, but collectively they provide stability to the transverse arch of the foot. Importantly, the plantar ligaments are the strongest, reflecting their role in weight bearing. Although rarely discussed, injury to these joints is not trivial. For example, in Lisfranc injuries, the instability often extends proximally into the intercuneiform joints, necessitating surgical fixation. Clinical integration. From a clinical perspective, understanding these joints and ligaments is vital. Conditions such as hallux valgus, hammer toes, plantar plate tears, flat foot deformity, and midfoot injuries all trace back to dysfunction or rupture of these structures. Moreover, when reconstructing arches surgically, such as in flat foot reconstruction, the surgeon relies heavily on restoring the integrity of ligaments like the spring ligament and the plantar ligaments of the calcaneocuboid joint. Radiographically, MRI is indispensable for visualizing plantar plate tears, spring ligament degeneration, and subtle intertarsal injuries. And biomechanically, every step we take demonstrates the intricate coordination of these small yet indispensable stabilizers.
In this part of our journey through the anatomy of the foot, we turn our attention to the plantar view, where the network of ligaments and tendons provides the foundation for stability, propulsion, and resilience of the forefoot. The illustration in front of you highlights just how complex this region is. Every tendon, every ligament, every attachment works together to transform the foot into both a shock absorber and a rigid lever during gait. The plantar ligaments and the architecture of the foot. Looking at the figure, we immediately notice the long plantar ligament and the short plantar ligament, also known as the plantar calcaneocuboid ligament. These two structures are essential to maintaining the lateral longitudinal arch of the foot. The long plantar ligament stretches from the calcaneus to the basis of the metatarsals, bridging over the peroneus longus tendon, which runs underneath it. This anatomical arrangement is not accidental. The ligament acts almost like a tunnel, guiding and protecting the peroneus longus tendon as it crosses the sole of the foot to insert on the base of the first metatarsal and the medial cuneiform. If this ligament complex fails, whether through trauma, chronic overload, or degenerative changes, the lateral side of the foot collapses, producing painful flat foot deformities. The spring ligament complex. Medially, the plantar calcaneonavicular ligament, more famously called the spring ligament, is seen attaching from the sustentaculum tali to the navicular. Together with the posterior tibial tendon and the deltoid ligament, the spring ligament forms the cornerstone of medial arch stability. Clinically, degeneration of the spring ligament is a hallmark of adult-acquired flat foot deformity. On MRI, this ligament often shows thickening and signal changes in patients with posterior tibial tendon dysfunction, and failure of this ligament leads to collapse of the talonavicular joint and subsequent valgus alignment of the hindfoot. The Lisfranc joint complex. Moving distally, we encounter the tarso-metatarsal joints, also known as the Lisfranc joint complex. This articulation is critical. It represents the keystone of the transverse arch of the foot. The second metatarsal base wedges tightly between the medial and lateral cuneiform bones, giving it a mortise-like stability. The Lisfranc ligament, a strong interosseous ligament running from the medial cuneiform to the base of the second metatarsal, is the primary stabilizer here. In the figure, you can appreciate how the plantar ligaments also contribute, but the Lisfranc ligament itself is unique and irreplaceable. When disrupted, whether by low-energy twist injuries or high-energy trauma, the Lisfranc joint becomes unstable. This results in mid-foot collapse, often requiring surgical fixation with screws or plates. Clinically, the so-called flex sign on radiographs and avulsion fragment at the base of the second metatarsal is pathognomonic for Lisfranc injury. Metatarsophalangeal joints. The MTP joints are depicted here with their capsules and reinforcing structures. These are condyloid joints, allowing flexion, extension, and limited abduction and adduction. Each MTP joint is stabilized by collateral ligaments on the sides, which resist varus and valgus stresses. On the plantar aspect, the plantar plate is the key structure. It is a fibrocartilaginous thickening of the capsule that prevents hyperextension of the joint and provides an attachment point for the plantar fascia and flexor tendons. The plantar plate of the first MTP joint is especially robust, as it must withstand the enormous pressures of push-off during gait. Clinically, rupture of the plantar plate, most often at the second MTP joint, is a common cause of metatarsalgia and crossover toe deformity. In athletes, hyperextension injuries can avulse the plantar plate from its metatarsal attachment, leading to chronic instability and pain.
The sesamoid apparatus. Within the tendon of the flexor hallucis longus, we find the sesamoid bones beneath the head of the first metatarsal. These sesamoids are not merely incidental, they act like pulleys, redirecting the pull of the flexor hallucis longus tendon and absorbing weight-bearing forces during push-off. The intersesamoidal ligament connects the medial and lateral sesamoids, while the plantar plate holds them against the metatarsal head. These ligaments together form the sesamoidal apparatus, which is essential for stability of the hallux. Clinically, sesamoid injuries, whether stress fractures, osteonecrosis, or sesamoiditis, are notorious causes of forefoot pain, particularly in runners and ballerinas. The sesamoids are also critical landmarks during bunion surgery, as malalignment of the sesamoids contributes to recurrence of hallux valgus deformity. Intermetatarsal and deep transverse metatarsal ligaments. Between the metatarsal heads, the deep transverse metatarsal ligaments bind the heads together, preventing excessive splaying of the forefoot. These ligaments also provide a roof under which the interdigital nerves run. When this ligament compresses the nerve, patients develop Morton's neuroma, classically between the third and fourth toes. These ligaments, together with the intermetatarsal bursa, are therefore critical not only in maintaining foot structure, but also as a common source of forefoot pain in clinical practice. Interphalangeal joints. Finally, the interphalangeal joints, simple hinge joints, are stabilized by collateral ligaments and plantar plates. They allow flexion and extension of the toes and prevent lateral deviation. Although small, these joints are clinically important. Deformities like hammer toe, claw toe, and mallet toe all result from imbalances of forces across the interphalangeal joints. Clinical integration. When we step back and look at this entire system, the plantar ligaments, the Lisfranc joint, the MTP and IP joints, we can appreciate the balance between mobility and rigidity. The foot must adapt to uneven terrain, absorb shock, and then transform into a rigid lever to propel the body forward. Failures in this system presents with distinct pathologies: Lisfranc injuries with midfoot collapse, plantar plate tears with toe deformities, Morton's neuroma with interdigital pain, sesamoiditis with focal hallux pain, and spring ligament degeneration with acquired flatfoot. Surgeons treating these conditions must understand not only the anatomy, but also the biomechanics of each ligament and joint. And for radiologists, recognizing subtle ligament injuries on MRI is critical in guiding treatment.